Hello everyone, I am Dr. Puneet, neurologist from Kanpur, and today I will talk about clinical syndrome or clinical features of brain ischemia. In this topic, as it is second part in this stroke series, so although I tried to simplify as much as possible, but I don't think that this lecture be beneficial for non-medicos. This is very beneficial for MBBS or MD or DM student, but for non-medicos, it might be a tough, tough video. Okay, because some technical word will be used in this session. So, firstly, I will discuss about transient ischemic attack or TIA. TIA are temporary focal neurodeficit involving either carotid circulation or vertebrobasilar circulation. Carotid circulation TIA present with ipsilateral monoocular vision loss, which is transient, also known as amaurosis fugax or contralateral hemiparesis, hemianopia or field defect, or patient is having aphasia. And vertebrobasilar TIA, they present with bilateral or shifting hemiparesis or complete vision loss or dysphagia, dysarthria, diplopia, ataxia, some or combination of these symptoms might be there. Why this TIAs are important? Because 1 in 10% develop full-blown stroke within 3 months, and 50% of this do so within 48 hours. So if you miss TIA, the same patient will come to you in 1 or 2 days with full-blown stroke. Now deal with that. Okay, so these TIAs are very important, and the symptoms are non-marching. Non-marching means they involve one half the body or a field through and through from the onset. They are not progressive from one part to other part, as seen in case of seizure. Jacksonian march is there. Okay, so this is all about TIA. Uh, then now I will discuss about carotid artery syndromes. If carotid artery is involved, carotid artery stroke, if there is a blockage in a carotid artery, then it lead to dense hemiparesis due to motor cortex involvement, and eye looks towards the lesion because of contralateral gaze palsy, because of involvement of frontal eye field, blindness to the same side of eye. Okay, field defect might be there. Patient might have global aphasia, unable to comprehend and speak normally. So this is about the carotid artery involvement, and the two terminal and two major branches of this carotid artery is middle cerebral artery and then anterior cerebral artery. If this middle cerebral artery is involved, if a stem of this middle cerebral artery is involved, then patient will have dense hemiplegia along with global aphasia if dominant side is involved, and hemi neglect if non-dominant side is involved or right side is involved. If superior division of this MC is involved, then patient will have Broca's type of aphasia. Means patient is unable to respond to verbal command, although he comprehend normally, but he is unable to respond you because of lack of articulation. Okay. Then and weakness, patient also have weakness to opposite side of the body, which is more in upper limb than in lower limb. So if dominant side is involved, then Broca's aphasia. If non-dominant side is involved, then patient is having eprosody or loss of prosody, melody of the voice. Okay. Now if inferior division is involved, if it is at the dominant side, then patient is having Wernicke's aphasia, means patient is unable to comprehend your spoken word. So you ask him something and he replies something else to you. And if right side or non-dominant side inferior division MC involved, then patient present with behavioral abnormality. Then if suppose ACA or anterior cerebral artery, if anterior cerebral artery is involved, which is most commonly involved in subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage due to vasospasm, and that lead to weakness which is more in lower limb than in upper limb, and along with this patient is having transcortical motor aphasia, Broca's type of aphasia, unable to speak, respond you properly. Okay, sometimes abulia or akinetic mutism might be present. So this is carotid artery syndromes. Then vertebrobasilar syndrome. Vertebrobasilar syndrome, two vertebral artery moves up to the level of pons and they unite to form basilar artery. Then basilar artery at, at the top divided into posterior cerebral artery. These posterior cerebral artery supplies P1 segment supplies midbrain, then P2 segment supplies temporal lobe and temporal lobe and thalamus, and then this P3 segments which supplies parieto-occipital and calcarean artery, and parieto-occipital artery supplies occipital cortex. So suppose if this PCA get blocked, if this PCA get blocked, then if there is any clot in this PCA, then it may lead to midbrain syndromes, or it may lead to thalamic syndromes, or it may lead to uh, hemispheric symptoms of hemianopia. So I'll discuss a little bit about this PCA involvement. If P1 segment is involved, then patient is having midbrain involvement along with thalamus involvement. Thalamus involvement lead to sensory type of a sensory or sensory motor stroke, and then this temporal cortex lead to amnesia, and then this occipital cortex lead to field loss. Now, if P2 segment, two major branches of artery of P2 is anterior temporal artery, which supplies hippocampal area. So its involvement on the left side leads to amnesia. And then this posterior temporal artery, also known as occipitotemporal artery, its involvement lead to Wernicke's type of aphasia. Again, patient is unable to comprehend. Transcortical sensory aphasia. Okay, then P3 divided into the parieto-occipital artery and then this calcarine artery. Calcarine artery lead to the field loss, and parieto-occipital artery involvement as it supplies splenium of corpus callosum. Patient is having alexia without agraphia, means patient is unable to read, but he write normally. So these are PCA territory involvement, PCA artery involvement syndrome. Now, before understanding this brainstem, vertebral, basilar, PCA, SCA, anterior cerebral, posterior inferior cerebral artery, their involvement, you have to remember rule of 4. What is this rule of 4? Four cranial nerve nucleus are midline. 3, 4, 6 and 12. 3, 4 at the level of midbrain, 6 at the level of pons, and 12 at the level of medulla. And then 5, 7, 9, 10, 11. 5, 7 at the level of pons, and 9, 10, 11 at the level of medulla. They are laterally located. Okay. Cranial nerve 1, 2 and 8 have no motor nucleus. They are sensory, pure sensory. Cranial nerve 1 or olfactory, it's into the temporal cortex, inferior temporal area, where it leans into the prepiriformis and periamygdaloid area of temporal lobe. Okay, it is smell for smell. Then visual or second nerve, it into the visual cortex, and then this auditory nerve, this cochlear and vestibular, two portion are there. So this cochlear portion while entering into the pontomedullary junction into the pons, and then in lateral lemniscus ascend up to the level of medial geniculate body into it is into the midbrain, and then from medial geniculate body it enter into the temporal cortex. Okay. Second rule is 1, 2, 3, 4, they are above pons. 5, 6, 7, 8 at the level of pons, and 9, 10, 11, 12 below pons or at the level of medulla. Okay. Then the third rule is 4 structures are midline. Four, what are these four structure which are midline? Motor tract, medial lemniscus, medial longitudinal fasciculus, and medial nuclei. And four structures are lateral. What are they? Number one is spinocerebellar tract, so its involvement lead to ataxia. Second is spinothalamic tract, so its involvement lead to contralateral thermoanesthesia. Then third is spinal nucleus of fifth cranial nerve, its involvement lead to facial thermoanesthesia, ipsilateral facial thermoanesthesia, and then sympathetic fibers, its involvement lead to ipsilateral Horner syndrome. So once this vertebral artery it's enter into the pons, before this it gives rise to the pica and it directly supplies medulla. So if pica or medulla involved, patient may have lateral medullary syndrome. And what happened in this lateral medullary syndrome? Lateral side of medulla is involved, and as I already said, patient is having um, ipsilateral ataxia due to spinocerebellar tract involvement, then contralateral thermoanesthesia due to spinothalamic involvement, then uh, sensory nucleus of facial nerve involvement lead to ipsilateral facial thermoanesthesia, and Horner syndrome because of sympathetic fibers involvement. As I already said, 9, 10, 11, these nerve located laterally in the medulla, so their involvement lead to dysphagia, dysarthria, and impaired gag reflex. And suppose medial part of this vertebral artery is involved and it lead to medial medullary syndrome. So in medial medullary syndrome, patient is having ipsilateral 12th nerve involvement, contralateral joint position vibration due to posterior column involvement, and then this pyramidal tract involvement lead to contralateral hemiparesis. So this much complete. Then at the level of pons, this basilar artery first branch is ICA. ICA supplies lateral inferior pons, and its symptoms are due to spinothalamic tract. As I said, lateral structures are spinocerebellar tract, so ipsilateral ataxia, spinothalamic tract to some contralateral thermoanesthesia, sympathetic fibers, so Horner syndrome, and fifth nerve nucleus, sensory nucleus, so thermoanesthesia, and seventh and eighth cranial nerve, as it goes at this point, so ipsilateral facial, and due to eighth lateral lemniscus involvement, so deafness is there. So this is all about ICA syndrome. Then if medial side of inferior pons is involved, as in case of Foveale syndrome, so medial side due to involvement of paramedian branch of basilar artery, and its involvement lead to involvement of paramedian pontine reticular formation. And if PPRF is involved, you all know PPRF uh, um, PPRF lead to the gauge towards the same side, so ipsilateral gauge paralysis is there. Eye looks away from the lesion, so eye is deviated opposite side towards the opposite side, okay, in Foveale syndrome. And one ventral pontine syndrome is there. In this ventral pontine syndrome, patient is having sixth and seventh nerve with contralateral hemiparesis, but here sixth nerve is involved, so only abduction of ipsilateral lateral rectus is involved, adduction is not involved. So this is difference between Foveale and Miller-Tubular. Then SCA supplies superior lateral pons. So if superior lateral SCA is involved, superior lateral pons is involved, and symptoms is again due to involvement of spinocerebellar tract, patient is having ataxia, ipsilateral, contralateral thermoanesthesia due to spinothalamic tract involvement, and then facial sensation due to fifth nerve involvement, and then Horner syndrome because of this sympathetic plexus involvement, and lateral lemniscus involvement may lead to deafness also. So although higher level, but deafness might be due to involvement of lateral lemniscus. Okay. Then midbrain syndrome. Before discussing this midbrain syndrome, slide anatomy is important. So midbrain is divided into three parts: basis, tegmentum, and tectum. This basis is actually having corticospinal corticobulbar tract, and this tegmentum having red nucleus, and tectum third nerve nucleus. So third nerve, while arising from its nucleus, it runs through the red nucleus to the basis and then emerges out from the ventral surface. Okay, so if this basis is involved, then basis portion is involved, that lead to Weber syndrome due to corticospinal tract and third nerve involvement, so it's ipsilateral third nerve palsy and contractile hemiparesis. If this tegmentum red nucleus is involved, red nucleus containing spinocerebellar tract, so it's involved due to contralateral ataxia and ipsilateral third nerve palsy. And Benedict syndrome is a combination of both. It involves both basis and this tegmentum portion. So red nucleus is involved, lead to ataxia. Basis is involved, spinocerebellar tract is involved, so contralateral weakness, spinothalamic tract, and then corticospinal tract, and then this third nerve, so ipsilateral third nerve paralysis is there, and substantia nigra also involved, so that lead to the chorioarthritis type of movement. Okay, so this is mid-brain syndrome. Now lacunar syndrome. Lacunar syndromes, what happen in this lacunar syndrome? Actually, lacunar syndrome, lacunae are 0.5 mm to 1.5 centimeter, 1.5 centimeter cavities, lacunae, and they present with either pure sensory due to involvement of internal capsule or basis pontus, or sensory motor presentation because of thalamus and internal capsule involvement, or pure sensory due to thalamus involvement, and then ataxic hemiparesis, ipsilateral hemiparesis, ipsilateral ataxia, contralateral hemiparesis due to involvement of this basis pontus, and then clumsy hand dysarthria syndrome, again basis pontus involvement, and lead to clumsy hand dysarthria syndrome. So this is all about this lacunar syndrome, and most of the patients are diabetic, hypertensive, or a smoker. And then last, watershed infarct. Watershed infarct, these occur because of hypotension, sudden hypotension, as occur in cardiac surgeries or at the time of CPR, and these involve either watershed area between ACMCA or MCA-PCA. If watershed area between ACA and MCA is involved, then patient is having sensory motor weakness of both the upper limb, that is known as man in barrel or person in barrel syndrome. Or if MCA-PCA territory, watershed area between MCA-PCA is involved, then patient is having cortical blindness or dyslexia, dysarthria, dysgraphia, features something sometimes similar Gesterman syndrome. Okay, so this is all for today, and next time I will discuss about the causes and investigation of this stroke patient. Okay, thanks for listening me. Thank you very much.